Hello, everyone. Thank you for joining me today. My name is Holli DeVon, and I'm the Associate Dean for Research in the School of Nursing at UCLA. I would like to thank Sigma for the honor of being inducted into the Hall of Fame, and thank you for taking the time to join me for my presentation today. My topic is symptoms, sex differences, and special populations. Building the science of ischemic heart disease. This is my disclosure slide. You can see my learner outcomes. I have no conflicts of interest to disclose, and I would like to acknowledge the National Institutes of Health for the grants that they have given me that supported the research that I'm presenting to you today. And this presentation is dedicated to my wonderful sponsors, Dr. Susan Dunn and Carol Ferens from the University of Illinois at Chicago, and Dr. Ann Rosenfeld from the University of Arizona. So my objectives today are three. First, it starts with mentors, then building a program of research, and finally paying it forward. The mentee becomes the mentor. So my philosophy of mentoring is that successful people never reach their goals alone. And I love this picture because you can see the mentor is at the pinnacle of this mountain, reaching down to help the mentee to the top. So I want to share with you some of the best mentors ever. This is Dr. Mija Kim. She's Dean Emerita at UIC, and she was my master's advisor. And then the awesome Dr. Marjorie Powers, who was my thesis chair in my master's program. And Dr. Julie Zerwick, who is now the dean at the University of Iowa. And last but certainly not least, Dr. Sally Rankin, who was my postdoc sponsor at UCSF. So I'd like to share this graphic, which is really a summary of my cardiovascular program of research. So I divided it down into 4 domains. First, the concepts that I have focused on, which are symptoms and sex differences. Next are the populations of individuals that I have studied, including people with acute coronary syndrome and patients with stable angina. And my primary outcomes of interest have been pain and symptom relief, symptom management, and quality of life. And finally, the measures that I focused on in my research include the 13-item acute coronary syndrome symptom checklist, which I began designing in my dissertation study and tested over the years, and then biomarkers of inflammation. So my research interest began with clinical problems that I observed when I was a CCU nurse, particularly sex disparities in cardiac cath results. So I was often sending my female patients to the cath lab, and they were coming back with a negative cardiac cath, meaning no significant occlusion of a main coronary artery. But unfortunately, this often left them with no diagnosis and no treatment plan and a lot of uncertainty. Meanwhile, in most cases, I was sending my male patients down for a cardiac cath, and they were coming back positive, meaning occlusion of 70% or more. And in most cases, they were receiving angioplasty and or a stent. And then they were getting guidelines-based care. So I asked myself, why is this happening? What could be the potential explanations? So when I got to the PhD program, I started searching the literature for any explanation for these, I called gender-based symptom perceptions at the time, but switched to the term sex differences because mainly we've looked at a biological approach. And so what I determined from the literature at that time became a model of 4 domains, including psychosocial differences, anatomical differences, physiological differences, and biological differences. And the details of the differences that I found are in this model. So this led me to believe, could it be primarily symptoms that drives people when they seek care, and either they're actually different, or they're perceived to be different, or they're reported differently. So as many of you know, the primary symptom of ischemic heart disease is left-sided or central chest pain, center of the chest. And this diagram shows you frequently reported symptoms by patients who are having myocardial infarction, including jaw, neck, both shoulders, across the chest, the upper abdomen, and both arms. And then this diagram shows, of course, a gentleman in the center who's holding his abdomen. And patients frequently describe their pain as heartburn or indigestion when they're having an MI. And you can see this woman is rubbing her jaw. And then finally, the classic substernal chest pain represented here. So I reviewed the literature looking at sex differences and symptoms of ACS. Now, this was around 2000, and there were only 12 studies that fit my criteria. And in analyzing those studies, I found that women experienced more back pain, jaw pain, nausea, dyspnea, palpitations. And the men with a diagnosis of MI only had more chest pain and diaphoresis, but there were no differences for men with unstable angina. So 12 studies only. Now, if we did a lit review 20 years later, we would probably find hundreds of studies, and many of them would be ours. So these findings led me to prepare a grant to examine sex differences and symptoms of ACS. So this was a cross-sectional study. I collected data at 2 large medical centers in the Midwestern United States. I enrolled patients within 72 hours of admission to reduce the problems with recall. We had a total of 256 patients hospitalized for ACS, and our primary instrument of many variables was the 13-item ACS symptom checklist. So these were the main findings of that study published in the American Journal of Critical Care. We found that women reported significantly more indigestion, palpitations, nausea, numbness in the hands, and unusual fatigue. Also, chest pain did not differ between women and men in this study. So if you take a minute and look at these symptoms, you wouldn't even have to be a CCU nurse or an expert to see that some of those symptoms are symptoms many of us have on a routine basis and are certainly nondescript and not specific for a heart attack or heart disease. So another critical problem that we identified in the study was delay in going to the emergency department. And we found that older patients and those with intermittent pain sought treatment later than younger patients and those with constant pain. And also that chest pain was not predictive of time to treatment. So some background: delay in going to the emergency department for symptoms of a heart attack has been way too long for decades. And prior clinical trials have done little or nothing to reduce delay time, and yet we've significantly reduced in-hospital delay time. And what concerned us was that older patients are the high-risk group. And chest pain is a symptom that even the lay public are familiar with. So we had identified other gaps in knowledge at this point, including, do symptoms co-occur? Most of our patients were reporting multiple symptoms. And if so, if symptoms co-occur, would clusters help us identify a higher risk group, or would they help us to deliver more precise care? So we analyzed our data and we used a latent cluster analysis to cluster subgroups of people. We didn't use a cluster analysis to cluster the symptoms, but rather people. And we found 4 clusters. We labeled the first cluster heavy symptom burden. These were patients experiencing a lot of symptoms. The second was chest pain only, and those were people who were experiencing chest pain, discomfort, or pressure. Class 3, we labeled short of breath and weak. And finally, the last group was we labeled sweating and weak. So critical problems remained in the science. By 2008, we had identified some sex differences in symptoms. They were fairly congruent with our original literature review, but we still didn't know if these sex differences mattered. So I mentioned we hadn't seen a reduction in pre-hospital delay. And the most important thing is time is muscle. So nowadays we have many ways to extract a clot if someone is having a heart attack, especially ST elevation MI, which is a total occlusion of a main coronary artery. We can do angioplasty, we can extract the clot, we can put a stent in. But after 3 hours, there's significant diminishment of returns. In other words, we need to reach the patient between minutes and about 3 hours, maybe a little bit later, to salvage myocardium. And then also, the lack of knowledge of symptoms other than chest pain for ACS. So we actually found this sign in one of the emergency departments where we have done our research. And as we all know, in the majority of cases, we don't have a diagnosis on admission to the emergency department. We just have a hypothesis. The patient presents to triage, they get sorted by urgency. And so patients have realized when they see that sign, if they don't want to wait in a busy emergency department, they may just say they're having chest pain. So this led to our next study, characterizing sex differences in symptoms of acute coronary syndrome. So we now were performing a longitudinal study. We measured symptoms this time in the emergency department when patients presented to triage. So in many cases, the patients were still having symptoms. So we enrolled 1,064 patients from 5 busy emergency departments across the country. And patients were eligible if they had symptoms suggestive of acute coronary syndrome and they received a cardiac workup. They were excluded if they had an ongoing diagnosis of heart failure because of the overlap of symptoms, or if they were referred for arrhythmias and they were asymptomatic. We wanted patients who made a decision on their own to seek care. So these were the key findings from the study. Women with acute coronary syndrome reported a higher number of symptoms, and significantly more nausea, shoulder pain, and upper back pain. In this study, women reported less chest pain. And older patients and patients with diabetes have less chest pain. So we were very troubled by this finding because, as I mentioned, older patients are at higher risk for ACS, and patients with diabetes is an equivalent, an anginal equivalent. So patients with type 2 diabetes, we automatically assume have coronary heart disease. So as I mentioned in the beginning, we wanted to examine disparities. So we've looked at disparities by sex, and now we looked at disparities by race. And so we published this analysis, and we said it matters if you're Black or white. So in our study, Blacks with confirmed acute coronary syndrome were younger, they had a lower income, they had less education, they had more risk factors, they had more symptoms, they had a longer pre-hospital delay, they made more visits to the clinic when they were discharged, and they had more symptoms at 1 month following discharge. And for those Blacks that were experiencing palpitations, unusual fatigue, and chest pain, were more than 3 times as likely as whites to have ACS confirmed. So our results confirmed something that we have all known. since the beginning of research, and that is people of color are disadvantaged on risk factors, on treatment, on outcomes. And we have to do better in working to abolish these disparities. So we were also interested in looking at sensitivity and specificity of symptoms because we had two cohorts in this study. Recall that patients who presented with symptoms suggestive of ACS and got a cardiac workup were included. So we had 600 patients ruled out for ACS and about 464 patients ruled in for ACS. So we were able to compare the two groups on symptoms. And what we found was chest pressure, chest discomfort, and chest pain demonstrated the highest sensitivity for ACS in both women and men. And we kind of expected this. We also found that women were twice as likely to report shoulder and arm pain compared to men with ACS. And if you recall, in one of our earlier studies, we found similar findings. So now we have more support for the findings in a large heterogeneous sample. And then finally, shortness of breath was a significant predictor of ACS in women, but not men. And this reminded me of a woman that I recruited to my dissertation study who told me that her husband called 911 when her symptoms started, and her most severe symptom was shortness of breath. And the paramedics asked her over and over again, do you have chest pain? Do you have chest pain? And she finally looked at one of them and said, do I need to have chest pain? Because if I do, I have it. So she was very savvy, but this goes to show that practitioners have a bias and they're looking for something to support the diagnosis. In this case, she was positive. But it just shows that we really need to listen and we need to have the evidence to support what we're looking for. So we had many analyses and many papers from this study, and I'm happy to report that one of my pre-doc students, Dr. Sahara Mirzai, did a secondary analysis of our data, and she published this paper as one of her dissertation papers, looking at the association between symptom onset characteristics, what was happening when symptoms started, and pre-hospital delay. And these were the key findings from her analysis. The median pre-hospital delay time was 4 hours. So as I said, that's too long because by that time people have irreversible myocardial damage. Being uninsured was associated with longer delay, which is not surprising. It's very expensive to call 911. And a diagnosis of ST elevation myocardial infarction and arrival by ambulance were associated with shorter delay. Well, as I mentioned, we don't know the diagnosis until the patient goes through a workup. The patient doesn't know the diagnosis when they're at home experiencing symptoms. So the ST elevation MI is really a proxy measure for something, but we don't know what yet. So delay times were shorter for patients who experienced abrupt versus gradual symptom onset. And this was important because this was first reported by O'Donnell and colleagues in Dublin, Ireland. So we confirmed the same thing in a different cohort of patients. And I do want to say that Sahara's paper was the most cited paper in the European Journal of Cardiovascular Nursing last year. So over the length of these studies, what are our key findings? So putting it all together, we have found women and men vary on less typical symptoms. Women are older, they delay longer in seeking care, and they have poorer physical functioning and are more depressed. Older patients and patients with diabetes have less chest pain. The majority of patients are experiencing multiple symptoms along with chest pain, and this often confuses them. And symptoms present in clusters. Chest pain alone is rare. And patient decision delay remains excessive and does not meet American Heart Association guidelines. So we have found a lot. We've contributed to the evidence base, but we know after 20 years of research that symptoms alone do not give us a lot of information, and that the patients who go on to be ruled in versus ruled out look very similar and we need to do a full workup on them. So I want to tell you a little bit about my current research. In 2018, I was privileged to receive a Fulbright U.S. Scholar Award, and I spent the spring semester in Rwanda. And here I am presenting stethoscopes that were donated by UIC faculty. And here's a seminar in progress. And in the last picture is me with one of my collaborators, Dr. Darius Kashoma, and Dean Donatilla Mukamana, Dean of the School of Nursing. And finally, this photo is women who survived the genocide in 1994 doing artwork and putting it up for sale. And you can see they're making beautiful trivets that I use as wall hangings. And they can bring their children and they can commune with one another. So it's a wonderful opportunity. So while I was there, I did a pilot study looking at the traditional and novel predictors of early cardiovascular disease risk in HIV-infected Rwandans. And this beautiful woman in the red dress is Dr. Brenda Katira. She's an HIV physician, was another collaborator on the study. So we aim to determine if individuals with HIV compared to age and sex-matched individuals varied on traditional and novel risk factors. And we define novel as inflammatory and immune factors. And we also want to determine if psychosocial factors are associated with CV risk and if they vary by sex. And in particular, because of the genocide, there's high rates of PTSD. So our first paper is under review now, and we're very excited to hope to continue that research in Rwanda. I'm also doing another study on pre-hospital treatment seeking delay for symptoms suggestive of ACS. As you know, we haven't made good progress. So we're looking at multiple clinical predictors as well as transportation and systems variables for this study. And I've submitted an abstract to American Heart and the paper's ready to go, so we're excited about that. And finally, I am doing a randomized controlled trial of acupuncture for angina, with my co-PI, Dr. Judy Schlager. And we're very excited because just today we looked at the analysis of our data, and we have found some very strong effects and strong feasibility. These are the aims of our study. Our overall goal is the reduction of pain and symptoms for patients who have stable angina and are receiving guideline-directed care, but still have symptoms. And just a little preview, we had 100% retention in the acupuncture group. So we're excited. Stay tuned for those results. Finally, I wanted to briefly talk about the mentee, that's me, becomes the mentor. So my philosophy of mentoring is very congruent with our lovely former First Lady, Michelle Obama, who said, we have to be our best friends. We cannot compete and see one person's failure as our success. We can all rise together. And that's what we need to do. And I carry that with me when I am working with my own students and scholars. And I just wanted to share some of my exceptional mentees, Dr. Catherine Breen, who just graduated a few weeks ago, an RWJF Future of Nursing Scholar. She did a secondary analysis of our data examining the presence of multimorbidity clusters in patients. And she's received a postdoc on a T32 at Emory University, so she'll be heading to the Woodruff School of Nursing in August. And Dr. Jessica Zagray-Hemsey, I am a co-sponsor on her K23 at UNC. This is a news release UNC put out, and she's studying patient-reported symptoms of ACS in pre-hospital cardiac care. She's working with the fire department and paramedics in her area and using the ACS symptom checklist to monitor symptoms from the first call to 911. And then Dr. Mark Lockwood, also I am fortunate to be a co-sponsor on his K23, and he's looking at changes in oral and gut microbiota and incidence and severity of patient-reported symptoms in pre- and post-kidney transplant patients. And then the aforementioned lovely Dr. Sahara Mirzai is now a postdoc fellow at UCLA, and her primary sponsor on her F32, which she'll submit in a few weeks, is Dr. Jake Lucis, and I'll be a co-sponsor, and she's studying cardiac risk and the gut microbiome. Finally, as you all know, in this age of COVID-19, we are separated, and hence I'm recording this presentation to you. But one of our scholars, Dr. Gloria Suwitse, in the oval here, just graduated. She received the Dean's Nursing Science Award. And there's me with the eyes closed, holding up a sign. And we had a surprise party, a virtual surprise party for her graduation. And over here is her new postdoc mentor. She received a very competitive postdoc fellowship to Dartmouth, and she is studying adverse childhood events and psychological trauma in children born of rape during the Rwandan genocide. So you can see I am very fortunate to work with an amazing group of collaborators and students, and what a wonderful opportunity I've had to add some evidence to heart disease. So I thank you so very much for your attention. Here is my email. Please don't hesitate to email me if you'd like to connect. And I believe we'll be having a live question and answer session after this. So thank you for your attention and have a wonderful day.